Good evening, everybody. Welcome to this class organized by NCSI. Today, we will be talking about intracerebral hemorrhage. This is a very common topic. As students, it's a topic for discussion to patients we see once you pass out of your student life. It's a very common problem we see around everywhere. A lot of patients, most of the patients we see, probably half of the patients of stroke come with intracerebral hemorrhage. So we have with us Dr. Shashank, who is an assistant professor in the Department of Anesthesiology at AIMS Bathinda. He will be talking to us about what is ICH, what causes these, how do we deal with it. Hmm? So I hope all of us are ready for an hour of good exhaustive session of ICH. Okay, Dr. Shashank, over to you.
Thank you so much, Dr. Karthik, for such a warm welcome. And I welcome everyone who has tuned in. So let me start the topic. Give me a second. So till my presentation is getting uploaded, let me start. So the topic of today's discussion, intracerebral hemorrhage, already told by Dr. Karthik. Oh, I think the slides are uploaded. So, 1 second. How to enlarge it? How do I enlarge it? Can you, Dr. Karthik, can you see my slides? Can you see my presentation? Yeah, it's here now. Yeah. So, without any delay, now let's start the topic. Topic of the day is intracerebral hemorrhage. It is a medical emergency which huge number of people suffer with, and state. I mean, uh, at the very outset, I would like to say that the biggest culprit is chronic hypertension or uncontrolled hypertension, and the hypertension in our, especially in our country and region where the primary healthcare is not very good, and there is non-compliance of treatment of hypertension. So at the very first the pointer is that the hypertension control can immediately control the ICH number. So what is ICH? By definition, the spontaneous ICH is defined as brain injury which is attributable to acute blood extravasation into the brain parenchyma. It is a non-traumatic bleeding. Of course, it can be bleeding. It can be traumatic as well. Coming to, and it is the ICH is considered to be the deadliest and the most devastating subtype of stroke. As we all know, stroke are of two types: ischemic and hemorrhagic. Ischemic is the most common type, and then hemorrhagic. It can be ICH or it can be due to SAH also, which is subarachnoid hemorrhage, which can be because of delayed cerebral ischemia. And the most devastating thing of the ICH is that the mortality and the morbidity of this disease is huge, and it is disproportionate. Just to state a fact, case fatality rate ranges from 35% at 7 days and it goes up to 60%. I mean, 60% of the people die in 1 year. So let's quickly classify it. It can be classified on the basis of cause, the origin, and location. Cause, as we already discussed, between traumatic, but most of them are spontaneous. Origin, it could be primary. Primary, again, the most common cause is uncontrolled hypertension, which is 50 to 70%. And then second, the primary cause is cerebral amyloid angiopathy, which is again 20 to 30%. And these two factors can, in combination, can also cause ICH. The secondary causes are one which in which there is structural cause or identified on the imaging. And coming to the next type of classification, ICH can also be classified on the basis of location. Basically, two types: deep and lobar. Deep are more because of hypertensive. It is deep, that is inside a basal ganglia or internal capsule of brainstem, cerebellum, thalamus, all those areas. Then the chances are it is because of hypertensive emergency. Or the lobar is more towards amyloid angiopathy cause. Now coming to the risk factors and the etiology, as I already said, 50 to 70% of ICH are because of uncontrolled hypertension, and these are usually the most common cause. The most common location of such ICH is in the pons, midbrain, thalamus, basal ganglion, and as you can see in the diagram, also they have seen some. I've shown some slides as well. These are, if these kind of ICH are most probably due to spontaneous ICH, and the etiology is because of uncontrolled hypertension. Now, the second most common type is cerebral amyloid angiopathy. It is either small vessel asymptomatic small hemorrhages, or it will be a lobar hemorrhage. This is a lobar hemorrhage, as you can see. Other causes or etiology are coagulopathies, as many patients in today's world, because of cardiac anomaly or etc., are on antiplatelets, antithrombotic, or they can have congenital deficiency systemic diseases which can cause thrombocytopenia. So basically, there is some sort of coagulopathy which may lead to the ICH. And also, we should always check for if there is ICH. We should always check for is the cause is because of there is any aneurysm, intracranial aneurysm, AVM malformation. In fact, the most common presenting feature of AVM in more than 60% is ICH. There could be cerebral venous thrombosis, also venous infarct, etc. So basically, a patient will come to emergency with loss, say low level of consciousness, history of headache, or signs of there will be vomiting, or the bradycardia, there will blood pressures will be high, or patient may be in coma. So all these things, immediately a patient should be sent to a CT scan and further evaluation, and differentiation of type of stroke, because ischemic, if the stroke is ischemic, then the management is totally different, and the hemorrhagic is different, which I'll cover in subsequent slides. So, talking about the mechanism of what happens once there is ICH, what really happens. So, there are multiple mechanisms which lead to the damage, both primary or secondary. So, the first and the direct impact is because of the large hematoma which has occurred because of ICH. So, there will be a direct injury which will cause mass effect. There will be mechanical effect. There will be perihematoma, edema, which may again give rise to ICP and impending herniation, etc. And then the biggest medical challenge in ICH is hematoma, expansion of how to contain that hematoma. So this hematoma expansion is seen very early in the ICH, and a leading cause of early deterioration as well. So up to a half of the expansion occurs in the very few. So first few hours are very, very crucial, and this may again lead to secondary injuries. Then again, I've already told about perihematomal edema. Perihematomal edema, the direct risk factor is the size of the hematoma. So if the size of the hematoma is more, the edema will be more. And again, the edema, raised ICP, hypoperfusion, then features different features of edema. Again, if the ICH or the lobar hemorrhage, like consider the lobar hemorrhage, okay, so if it is huge, or it may expand into say IVH and different parts of the brain, and so this IVH may again lead to some problems, or the damage of the brain. So IVH per se, if there is bleed in the say ventricles, inside the ventricles. It will disrupt the CSF function, CSF absorption, CSF production. So eventually you have to either evacuate it, and the this disruption of CSF formulation and absorption will eventually lead to hydrocephalus. So again, this in particular is a surgical intervention may be required. So these are the mechanisms. So coming to what happens when the patient comes, as I already told, the features with which the patient will come to our emergency room. So these will be again a stroke kind of headache, vomiting. So once the patient will come, so our first management, or the first responder will start with initial evaluation and clinical stabilization in stepwise manner. So first and the foremost is our ABC. So airway, breathing and circulation has to be stabilized and taken care of, like in different other scenarios, emergency scenarios. Then immediately, as I said, we need to know the different type of stroke. So we immediately need a non-contrast CT brain. So once clinical stability is achieved, immediately do the CT scan, and then after that we can we can do all these things simultaneously as well. Standardized neurological assessment to determine baseline severity and Glasgow Coma Scale. All these things have to quickly, and because this is an emergency situation and also we are running out of time, so this has to be done very quickly. Blood pressure management, reversal of coagulopathy and evaluation, that is how to contain that hematoma, will be covered in subsequent slides. And frequent neurological examination at least every hour if the patient looks stable, to detect early clinical deterioration and signs of increased ICP should be part of a routine initial management. So once the patient is stabilized, our next target is CT evidence. So coming to CT evidence, what I mean radiological evidence. So what radiological evidence? As I said, the first screening tool and very quick and fast is our non-contrast CT. So this is our first line. So we immediately do it. However, MRI is also good, but it will take time and we may lose crucial time. Now again, once CT is done, so CT angiography can also be done because it may give us great prognostic information. So once now let's prognosticate the our ICH today. So there is something called as ICH score, which tells the 30-day mortality due to ICH. So it has components like Glasgow Coma Scale, ICH volume, intraventricular hemorrhage present or not, with then intratentorial origin of ICH, yes or not, and then the age. And as you can see in this, there is no coagulopathy or there is no INR component in this because that is modifiable. We can quickly reverse. INR. I mean, we can quickly correct INR. So that is why it is not in this score. And as you can see, as I already told, that the mortality and the morbidity is disproportionate. So 30-day case fatality, if the total score is say 3 is 72%, 5 to 6 almost 100%. So coming to the fourth point, which is the second point, how to calculate ICH volume. So because the second component needs to be calculated. So basically, if we by physics, if we want to calculate volume of any shape, we simply need length, breadth, and the thickness. So the formula goes by ABC by 2. So the CT film which has the slides which has the largest hematoma, just measure the longitudinal axis, the greatest one, and draw a perpendicular line, and again the longest one. So we'll get A and B. And coming to the height or the thickness, so we will calculate the number of slices in which we can see hematoma, and we can divide by 2 because the usual thickness is 0.5 mm. So by this we will get the volume, and by knowing the volume we will get two informations. Now one, the hematoma burden on the brain, and second, um, the second, if it is expanding or not, because if it is expanding, then the patient is in really great trouble. So after, as I said, after prognostication, as we are currently discussing the hematoma expansion. As this is a slice of, this is a series of CT brain, non-contrast CT brain of a 57-year-old female who underwent ICH. So you can see the hematoma is consistently increasing, and the patient eventually died. So this is the most important part of the management. But before the management, we need to understand and we need to early diagnose this particular thing. So, how do we predict? How can we predict if the hematoma is expanding or not? So, basically, we can do it by three things. So, first is the time from ICH onset to CT. So, the patient came and the time taken for that patient to undergo CT and then interpretation. So, why this time is important? Because if the time is more than 6 hours, so you do not know what was the initial damage and what has happened in these 6 hours. So see the volume of the hematoma, the size of the hematoma will not give us a great picture. How what was the true picture? I mean, at the 0th hour, what happened, and between 6 hours, what happened? So the time delay will which means the hematoma has expanded. And the second, as I said, is patient is on warfarin. If the INR is greater, naturally the hematoma will grow. And the third one is the spot sign. What is spot sign? As I in 2 slides back I told about radiological imaging, that is CT angiography. So in CT angiography, the contrast, if the contrast will leak from the vessels and go into the hematoma, and there will be this hyperdense uh, spot sign. So again, this can be due to, there are two things in the spot sign: early spot sign and late sign. Early spot sign is nothing but the first pass CT angiography, which is the arterial phase, which will happen in initial 30 seconds, and then 30 to say for 4 minutes after you have injected the contrast, the picture will be of a second pass. So, however, if this spot sign is present or greater in early phase, it will be a worse prognosis, because the hematoma is expanding very quickly. So these by these three things, we can predict hematoma expansion. I mean, if hematoma is expanding or not. Now, after the diagnosis comes the management of the ICH. This is the management of the ICH can be divided into medical management, surgical intervention, the management of any added ICH complications like IVH, management of perihematomal edema, again because it may have devastating problems like herniation, and then the general things which we can do in the ICU to improve the outcome. So the goal of this management is simply either to evacuate the hematoma, let the brain relax, get rid of the hematoma, or we need to contain that the initial injury by the hematoma. We do not allow this hematoma to expand. So let's see all these managements one by one. So coming to the first and the most talked about and the most researched thing, what should be the ideal blood pressure management and what should be the thresholds? So quickly, there have been multi-centric trials. The most important ones are the Interact trial 1 and 2 and the Attach trial 1 and 2. So I'll quickly summarize. These what were the great findings of these mega trials. So, in patients with spontaneous ICH, mild to moderate severity, presenting with systolic blood pressure between 150 to, if the blood pressure of the patient who has presented with ICH is 150 to 220 mmHg, so acute lowering of systolic blood pressure to a target of 140 millimeter Hg with goal of maintaining between 130 to 150 is safe and may be reasonable for improving functional outcome. So these Interact trials have shown they have used multiple antihypertensive, and they have a study group, and they have seen harmful effects of suddenly lowering, acutely lowering within 1 hour, and they found out that the this there is the sweet spot. I mean, the good spot is 140, 130 to 150. However, if we go below 130, of course, it will lead to hypoperfusion, and the ischemic zone may increase, and may have other complications. So now we are, if the BP is between 150 to 220, then our sweet spot is 130 to 150, or 140 rather. And what if the blood pressure is even more than 220? So it may be reasonable to consider aggressive reduction of blood pressure. Again, aggressive means within 1 hour, quickly do it with a continuous intravenous infusion, and frequent BP monitoring. So now, what are the first line drugs? The first line drugs are labetalol and nicardipine. Attached to trial has studied nicardipine. So labetalol and nicardipine. If it is refractory, then we can use ACE inhibitors, and also thiazides and spironolactones have also been studied. And having said all these the nice things about blood pressure management, sometimes it is very, very difficult to control that blood pressure. That range 140, 150 is so difficult at times to manage, and the patients are usually like above 180 and 200, and as these trials have shown, above 80, greater than 170 in a test trial has poorer outcome. So it is hell of a challenge to manage BP and then eventually contain hematoma expansion. Coming to the management of anticoagulant related hemorrhage, I mean, how to reverse the ongoing anticoagulant taken by the patient, or if he has any coagulopathy. So the class 1 evidence is simply discontinue the anticoagulant therapy immediately. So usually the anticoagulants which are going are either vitamin K antagonist, or vector 10 inhibitors, or direct thrombin inhibitors. So if the patient is taking vitamin K antagonist warfarin and the INR is between 1.3 and 1.4, give 4-factor PCC. PCC is prothrombin complex concentrates, and these are considered better than FFPs. Why? Because these have 25 times more concentrated coagulating factors. So it is AHA's guidelines clearly say that they prefer, in fact, 4-factor PCCs. So if the INR is between 1.3 to 1.9, we can give 10 to 20 international units per kg, and if it is INR greater than 2, we can give 25. So we need to immediately and try to reverse vitamin K antagonist by giving PCCs. Coming to direct thrombin inhibitors, dabigatran. So we should know the history, when has the patient taken it. If it is less than 2 hours, then we can give activated charcoal. If it is less than 2, potential efficacy is up to 8 hours. However, there are expensive and the newer drugs, which is etarisuzumab, which is antagonist of dabigatran. However, it is not available anywhere. So if it is available, then good, then give it. Otherwise, we can again give PCCs or FFPs. Again, if patient is taking heparin, then protamine is its antidote, and it's again should be immediately reversed. And one more thing, what about antiplatelets? Because so many patients are on antiplatelets, like who have cardiac anomalies and diseases. So for platelet, it is recommended that no platelet transfusion is required if the patient is on anticoagulants. Platelet transfusion is only and only required if there is some surgical intervention, like if the surgeon wants to put an EVD, like in IVH. Only then, if the platelet count is low, only then it should be given. Otherwise, there is no indication of platelet transfusion. However, the drugs should be immediately stopped. Coming to the after the hematoma contained, we have tried we have learned the management of not allowing hematoma to expand, to evacuation of hematoma. So that can be done through surgical interventions. So a large trial, which is Stitch trial, has shown there is no benefit of early hematoma evacuation in case of superficial hemorrhages. However, the same trial has said that small survival benefits in superficial lobar hemorrhages is seen. So now the open craniotomy and evacuation, this is one surgical intervention. The second can be minimally invasive and along with clot lysis. So this technique incorporates removal of the hematoma in a single procedure using endoscope and image-guided placement of a drainage catheter followed by catheter irrigation with a thrombolytic agent to allow passive drainage of hematoma over several days. So this is minimally invasive. So because the early evacuation and it was not seen beneficial, then the researchers tried minimally invasive. So minimal invasive again trial has been done and third it has reached. So moderate to large intracerebral hemorrhage, no improvement, but large reduction of hematoma to say less than 15 ml has found to be beneficial. Coming to another surgical intervention, which is external ventricular, this is done in cases of if there is presence of intraventricular hemorrhage. Coming to decompressive craniectomy, aim of this surgery is to mitigate the consequences of mass effect, in particular that of delayed edema, or there is chances of herniation. Now coming to surgical management of IVH, as IVH already said, and coming to the evacuation or the threshold which is considered is if it is greater than 3 centimeter, the hematoma. So surgical management of IVH. IVH surgical management can be because of spontaneous IVH with if there is obstructive hydrocephalus, EVD should be done. There is good mortality reduction and functional outcome. If the spontaneous ICH which less than 30 ml, GCS is greater than 3, IVH requiring EVD, then IVD plus thrombolysis. If there is spontaneous ICH is less than 30 and IVH requiring EVD, so again, as one of the trials said, a neuroendoscopy plus EVD plus thrombolysis has been done. All these are surgical management of intraventricular hemorrhage. Now coming to the management of hematomal edema, as I said, a peritomal edema, the periphery of the hematoma will lead to perihematomal edema in the brain. It may increase. There are CT scans, serial CT scans, which can be done, and this edema can be seen. And the biggest risk factor again for this edema is hematoma size, hematoma expansion. So again, everything boils down to containing or reducing this hematoma. So, and this, the management is not done in the patients who do not show any symptoms of sudden raise of ICP. So if there is impending herniation, then the first line is again mannitol and hypertonic saline, and we can keep 145 to 155 sodium as a target that we should achieve this if we are giving hypertonic saline. And there have been studies where the hypertonic saline was quickly able to reverse the edema. However, there is nothing much to choose. And if there is something to choose, if there is congestive heart failure, then mannitol can be given. And if there's dehydration or decreased urine output, then we give infusion of hypertonic saline. And again, the earliest study has already also shown that if we remove the hematoma, there is significant edema reduction as well. So even surgical intervention can manage the perihematomal edema. Now coming once we have discussed about the medical management, the surgical management. Now the general things we do in ICU or the improve the quality in the acute stroke. So these are few points which needs to be discussed. So the number one is the glucose, the hyperglycemia. So patients may have hyperglycemia. Again, the range is around 140 to 180. Keep it there because less than that is very difficult to control and will have devastating complications. And more than that will show a very, very poor outcome. Coming to temperature patient may have hypothermia, and the studies have shown neither hypothermia or normothermia have impacted the prognosis. So basically, nothing can be done. As of now, there are no studies. So goal is to keep between 37.5 to 38 degrees Celsius. So again, coming to prevention of venous thromboembolism, in one because it's a prolonged ICU stay, patient may be there. So there are like 1 to 5% incidence of thromboembolism. But because patient we are reversing anticoagulation, so which has to be done. So naturally, we should start with intermittent pneumatic compression device. And if and only after that we can give pharmacological prophylaxis on fractionated heparin. That too after say 2 to 4 days of 2 to 4 days of hematoma has stabilized and it is not expanding. Only then coming to the treatment, nutrition and dysphagia, because dysphagia may be seen here and patient may land up in aspiration. So a formal screening procedure should be done. Anemia should be treated. Coming to seizure prophylaxis, because the lobar hemorrhages may be predisposed to seizures. And as of now, there are no recommendation for prophylactic anticonvulsants. Lobar hemorrhages are independent predictors of early and late seizures. There may continuous monitoring can be done, but if there is clinical seizures, only then anti-seizures can be given. Otherwise, there is no role of anti-epileptics. In summary, to summarize, we need to act very early and quick. The early diagnosis is very important. This is a medical emergency, and because it has a very bad prognosis, so in most of the ICUs, people are pessimistic about it, and they do not. I mean, DNR should be not recommended, and we should try till the end if the resources and everything is there. So again, to summarize, we should first stabilize the patient, and then we should immediately do the CT evidence, and then the medical management, that is the contain hematoma. If surgical intervention required, so be it. And then prevention of secondary brain injury in our general ICU. Stage stratification, again, the most important risk factor is hypertension. So we can prevent many ICH cases if we somehow in private healthcare and make patients control their BP. We could also prevent ICH. Uh, I hope this was very useful presentation. Thank you so much.
So, thank you, Dr. Shashank. That was a very exhaustive talk. I would love to add in a couple of things. So because see, I work as a neurointensivist in one of the hospitals of Bangalore. It's Sparsh. So here, what happens is I see a lot of patients with ICH. So I just wanted to discuss two cases which I recently did. We have had n number of memorable ones. So there was one patient who had an apparent transient ischemic attack. He was put on ticagrelor. Then he ended up having an ICH in his house. He was brought here. He had an ICH and IVH. In spite of decompressing him, the bleeding increased. It kind of trickled down till the midbrain. And again, his GCS was low. He took quite a long time to recover out of that. Then after that, I saw another patient who was an orthopedician by profession. In COVID, somebody said he has to take rivaroxaban, and he was taking rivaroxaban for about 8 to 9 months. Ended up having an ICH. He came to us, and we were not able to kind of reverse the drug because of the inavailability of proper the octoplex what we get here. And then so we had to wait for 48 hours because he presented almost 24 hours late to us. Then decompressed him. He's paralyzed on the left now, but again, not back to his functional status. So these were two old ones. And here let me just present my screen.
As I said, if the hemorrhage is in brain stem or things, places like that, there's no option but to surgically decompress it. There is no other option. And secondly, as you said, one more thing is that the dictum in our field is time is brain, because the patient comes so late. And I've also indicated in one of the points that the CT delay, the time the ACH has happened and the CT is done, the first CT, it may not give a correct picture because of the time. Say if the ICH happened at the house at 12 noon today, and the patient came and the CT is done at say 6 p.m. So in these 6 hours, so much has happened. But it is incorrect to see that 6 p.m. CT scan, because it may be that the hematoma has increased say 3-4 times.
True. Are you able to see my screen on yours?
Yes.
The CT.
No, I can't.
Okay. Can you
Should I?
have you stopped sharing your screen?
I think so. I should stop it. How to? Don't show these steps.
It's still showing me your screen.
Yeah, do not show these steps again. Share screen. I do not want to.
Okay. All right. So this young lady who is about 29 years old, who presented about 5 days after her.
I've removed my slides, so I think you may be able to now.
Okay, let me try.
Try one more time.
Yeah, let me try. Let me try. Anything visible? Nope. Okay, let me try to figure out. Hmm. Is my screen visible? Any CT scan?
I can see you. I think you need to upload your slides first.
No, it's not a slide. I'm pulling it out of
Achha, okay.
actually out of my packs directly.
I mean, you can upload it as well.
Mm, okay. All right. So coming back to this, so this lady comes about 5 days after her delivery. They say that morning she woke up during. Okay, she woke up and she went back to sleep. Then they find her to be weak and aphasic. They were in a tier 2 city from here. They visited the local doctor there. They got a CT done, realized she had an ICH. She came to us, and when she came to us, we repeated a CT, and there a few things what I noticed was she had bleeds of multiple densities. The blend sign was evident,
Okay.
and there was a rim of perilesional edema. So whatever bleed is there is not fresh. It's been there for a while. Probably she's had multiple episodes. We got a CT angio done. We couldn't pick up any spot sign or anything, but we went ahead, decompressed her. And the only thing startling us is we didn't have an etiology in this lady.
Mhm.
Only twice I just noticed that her blood pressure was on the higher side. Other than that, no. Just two episodes in the ICU. So we were just looking for reasons. Then we said, I can't find a reason. We'll go ahead, treat her and come. Then eventually she kind of her recovery has been fast. She's been coming around well, and she made it out. So if I was able to show the slide, it would have been an amazing.
A different attenuation is sure sign that the hematoma is expanded.
True.
Yeah, so that is a sign. And
Hmm. Anyway, okay, that was one. And then another case which I would want to discuss is.
and one
Uh,
more thing about the etiology. The
hmm.
etiology location of the this thing can also be identified on the CT scan. So again, if it is lobar, say it may be because of a myeloid angiopathy.
No,
These
it
it is
wasn't lobar.
hypertension specifically in say thalamus, pons. I mean thalamus, basal ganglia, and all those stuff. So we can, if there is no evidence of etiology, we can straight away. These are on the guidelines, so we can immediately say it is hypertension. But at times they are a mixture of both.
Mm-mm. Could be. No, that's what I was not able to pick a cause in this lady. Because throughout her, I checked her ANC records. Her systolic was always in the 90s for her, and here two episodes we saw were pretty high. Then after
A
that, just
DSA
two
was
short.
done. A DSA was done.
No,
Digital substitution.
We didn't do a DSA. We did a CT angio for her.
Okay.
Didn't find any pathology, so we just decompressed her. Although it was a left-sided lesion, she managed to come out without a trachea
Okay.
and shifted to a rehab, recovering well. Then this other case which I wanted to discuss is he's probably in his 30s, young male, hypertensive. We went to an outside hospital with vague symptoms, headache, uh, like tiredness and all that. So he was seen by a cardiologist who saw that, okay, there was some ECG changes, said it could be an ongoing MI, you come get admitted. Came, but all the tropi and all was normal,
Mhm.
and but he continued to have ECG changes,
Mhm.
and I should have got that ECG. And then he, with his persistent headache complaints, got a
Mhm.
CT done. He
Mhm.
had a massive IVH, no
IVF.
ICH, no
No IC.
ICH, massive IVH, entire left ventricle, third
Mhm.
ventricle, fourth ventricle.
Okay. I mean,
So
connected, so everything just spilled
hmm,
all over the ventricles.
So we were having a discussion. Has it gone from down? Did it bleed and go up, or from up has it come down, and all that? Then we said, okay, let's work him up. BP control was done, and then when we did an MRI, trying to look for
Of course.
a cause, the radiologist noted an abnormal vessel running across the midbrain.
Oh,
He said we need to do a DSA. Then we went ahead, did a DSA. Then DSA did not show anything. But surprisingly, without a sequelae, the
mm.
IVH just got reabsorbed
Just
in
real
about a matter of 10 days.
nice. So
Yeah.
EVD was put? No.
Sorry?
EVD, EVD.
No,
No,
nothing. No surgical intervention. We had
no,
explained to the
no hydrocephalus later.
nothing. I wanted to show these slides. I don't know. They're not opening. So it's okay. So these are a few cases, very interesting ones related to ICH that kept us on our toes. Mm. So we come across n number of things. So let me just see if we have any questions. I don't see any questions anywhere. Okay. Have any interesting cases to share?
As of now,
Mm,
I mean, the most common thing should be discussed. I mean, if there is
yes.
usually hypertensive, uncontrolled hypertensive with will come, or as I said, amyloid is again, it will again will be on a older side, say 50, 40. So again, etiology can be identified in a way by age or presentation also.
Okay.
And again, SAH can also show. AVM also. AVM, in fact, AVM, the most presenting feature is ICH.
True.
So, so that is why DSA is sometimes
Mm,
choice. A question has come. So
yep.
the choice
I
of
was just,
antihypertensive, as already told, the first line is nicardipine, labetalol. These two are, if refractory, then ACE inhibitors, and thiazide and spironolactone have also been studied, but nitrate should be avoided because we all know it may cause vasodilation. But
and
nitro, many things. See, when you cannot control blood pressure, then you have to do something. So it's a very aggressive early treatment. You have to be very aggressive.
mm. Do we have nicardipine available everywhere now?
No, not really. Ours is a very new institute. I joined here
Mm-mm.
one and a half years back, so ours is a very new. But
No,
we have
because
surgically we are intervening. I mean,
no, because I have not
but
been able to get my hands on nicardipine. So and most of the times what I've noticed is labetalol is not
labetalol,
enough.
labetalol
Uh,
is presented here. So
it's not enough
labetalol,
and causes. Sorry, you finish. I'll.
yeah, labetalol is present everywhere. So
Hmm.
labetalol.
Yes, and labetalol has a ceiling effect. You can't use more than 300 mg in a day. So I use nimodipine infusion.
Mhm,
I get it as a dosage of 1 mg per 5 ml, and
mhm,
it does wonders.
mhm.
Nimodipine is my drug of choice. I get a call even in the middle of the night. I said, you start them on a nimodipine infusion, everything will come under control. But yes, rarely I have come across cases which go into kind of refractory bradycardia, but they respond but the patient is symptom free. It's just what
You
we
know,
pick up.
coming back to it, the attached trial to
Huh.
used nicardipine. So if it is the BP is greater than 220, then infusion is very good, especially in nicardipine as per the studies. So it
Mm.
is around 5 to 15 milligram per hour nicardipine
Okay.
infusion.
Mm-mm.
No, it's not an absolute. NTG is not an absolute contraindication. It is said it should be avoided. As I said, it's a very aggressive treatment. So studies have been done. So NTG infusion have been studied and done, but should be avoided. You have better drugs, so we can do it. NTG has been studied.
Mm.
ICH in CKD patients.
Very common. Very
No,
common. ICH in CKD patients is because they have a low threat. Their BP is always on the higher side. And I've seen that a lot of patients who come with ICH after the round of dialysis, a lot of them don't make it out. But
naturally, because
mm,
comorbidity with such a big ICH will have poor prognosis.
when to start oral antihypertensive therapy?
I mean, our target is 140, so BP should be that's the threshold. So we should start when it is controlled immediately.
I think depending on the GCS of the patient, if the patient has a good GCS and we suspect that the swallowing is not going to be affected, I think we can start it at the earliest. Probably, I would want to wait overnight and probably start it in
I think initial treatment is emergency treatment. So first few hours, so it will be
IV.
difficult.
Mm,
After that, if it is well controlled, hematoma is controlled. I think.
yes. Have any more questions? Okay. I think the okay. How frequently should scan be done to see for hematoma expansion?
Um, One, if we have spot sign, as I already told, so if there is presence of spot sign through CT angiography, that means it is expanding. And I think there is some threshold value also greater than 30%, 32% or something like that, or the volume expansion. Then again, we can do it more frequently. If it is stable, then 40 to, I mean, per day, for 24 to 48 hours. Yeah. GCS, if it is not only GCS, if GCS we can
Mm-mm.
do it at every hourly or 30 minutes. GCS can be done. You have to check GCS. So if GCS deteriorates, it means something bad has happened. So immediate CT can be done then.
True. I think those are a number of questions, Dr. Shashank. So, all right, I think we can call it a day. Thank you
Yeah.
very much for a good exhaustive session.
Mhm.
It was nice looking into the mystery trials, what the new surgical interventions are, and getting in early, sorting out the BP, then preventing hematoma expansion. I think prevention of hematoma expansion is the key
Yeah.
factor here. Mm. So if the hematoma expansion is controlled, I think half the battle is won. It's just the rehab after that time. Mm. All right.
I couldn't agree more. Thank you so much, Dr. Karthik, for giving
My
me this
pleasure.
opportunity.
Mm.
Yeah, that's
Yeah. I would like to extend thanks to NCSI for giving us all this opportunity to learn about the topic, to get more insight and more information. Mm. Thank you very much.
thank you. Thank
Yeah.
you so much.